Everyone, welcome to ResearchMD.com. My name is Dr. PRAMIL. I'm a physician practicing in the United States, Program Director, Internal Medicine Residency and Transitional Residency, Associate Professor of Medicine, two large medical schools. We've been doing a series of lectures on antibiotic. Today our topic is about, yesterday we did like cephalosporin first generation. Make sure you watch that, it's very important. Now today we're going to concentrate on second generation cephalosporins, okay? So let's start like we usually do. Let's take a look back and how do we approach the presentation today, right? We got the, today again talk is the second generation, we got the structure of the cephalosporin, and then we have the structure of the second generation of cephalosporin. Then we're going to talk about the mechanism of action. I hope everybody can see this, and then resistance we're going to talk about. And then we're going to look at the gram-positive, gram-negative, and anaerobic coverage. Okay, and then general characteristics, and we're going to go cephachlor, cefuroxime, cefoxitin, cefotetan, cefprozil. Okay, that's our plan. So we need to know all this. So first thing we need to do is look at the structure of cephalosporin, right? This is a group of drugs. What is the structure? How does it differ from the penicillin? We need to know. Penicillin over here usually have this thiazolidine ring. Now, in this group of cephalosporin, what they do is that is replaced by dihydrothiosin ring. Okay, remember that. That is what's happening. In cephalosporin, you have a dihydrothiosin ring instead of the thiazolidine. Okay, now this beta-lactam ring remains the same. Penicillin have the beta-lactam ring. The cephalosporin also have beta-lactam ring, remember. Okay, so when we look at the second generation cephalosporin, they look at the R1 and R group, make some modifications to make new drugs. There's like few of them we're going to talk about it, okay? So the next thing you have to look at the mechanism of action. What does it do? Penicillin-binding protein, right? They inhibit the penicillin-binding protein of the bacterium. So what do we need? The penicillin-binding protein is very important to make this peptidoglycan, which is the most important part of the cell wall of the bacteria. Okay, that doesn't work. Now, it's very important. Some of these drugs we cannot use because they develop resistance. So when you talk about resistance, we talk about penetration. If the penetration is affected, they can go into the cell. So Rickettsia, Legionella, others usually don't have any coverage. And there are some porins in the bacterial cell wall to transport the nutrients. That's affected. So Pseudomonas resistance can develop through that. And there is pumps. Bacteria have this efflux pump. Whenever antibiotics get into the cell, boom, we just pump it outside, okay? So Pseudomonas work that. Pseudomonas have a great pumping mechanism. So what do? They just, from the cell, they pump it out. So there is not enough concentration of the bacteria. And then the most important, you got penicillinase or beta-lactamase, which destroys the beta-lactam ring. So it doesn't have much gram-negative coverage. And they got a penicillin-binding protein, some mutations, the listeria and enterococci, and finally the peptidoglycan may be absent, like in the mycoplasma, it's not going to work. Okay? Now let's look at some of the coverage. You got some coverage. There's gram-positive, gram-negative, and anaerobic coverage we need now, right? Second, we are talking about second generation cephalosporins here. Okay, let's look at the gram-positive. It does have the coverage similar to the first generation cephalosporin. And cefoxitin and cefotetan have little activity. Remember that two drug, cefoxitin and cefotetan have less gram-positive activity. Now let's look at the gram-negative. Some E. coli, some Klebsiella, Proteus, a good drug against hemophilus and Moraxella. Okay, and then Neisseria has coverage also. The big difference is when you come to second generation, there's some anaerobic coverage here, especially against Bacteroides fragilis, anaerobic. Okay, cefoxitin, cefotetan has moderate coverage against Bacteroides fragilis or some anaerobic coverage. Now, let's look at some general characteristic therapeutic concentration achieved in most tissues. Remember, when we talk about the first generation, it doesn't reach CSF, it does not reach the middle ear. fluid, okay? So we cannot use it in the middle ear infection. But in this case, it just reaches every tissue, even CSF, but we'll come back to that. Now, let's talk about the first drug. 5 drugs we need to know. Cefaclor, cefuroxime, cefoxitin, cefotetan, and cefprozil. Okay, let's look at some of the dosage. When you talk about cefaclor, 1 gram Q8 hours, you can give oral, and then, the one complication is caused like serum sickness kind of reaction. And then you got cefuroxime, 3 gram Q8 SIV, or you can give oral 500 milligram every 12 hours. And then penetrate CSF, but delayed CSF sterilization, hearing loss. So even though it penetrates CSF, it can cause like CSF sterilization, usually not that good. And then also it can cause hearing loss. So we usually don't use it. And then we talk about cefoxitin, 3 gram every 6 hours. This is important because intra-abdominal and pelvic surgeries, we use it as a prophylaxis. And then it can cause pseudomembranous pseudomembrane colitis. Okay. Now, next drug is the cefotetan, 3 gram every 12 hours. And the next one, cefprozil, 500 milligram oral Q12 hours. And it can cause serum sickness like reaction. Thank you so much for watching. We'll be back with another presentation soon. God bless.